Now, the last but definitely not least part of the chapter will discuss hormones and the effect of hormones on calcium homeostasis. So why is calcium homeostasis so special that it gets a part in this chapter? Well, because calcium levels, deviations away from normal calcium levels, whether too high or too low, especially if it's in the extracellular levels of calcium, can actually lead to neurological and muscular activity disruption. We have learned that calcium levels are important for muscular contraction. We also know that calcium levels are important for the release of neurotransmitters from neurons. So any change in the normal levels of calcium will lead to neurological and muscular abnormalities. Now, the effector sites for calcium homeostasis, which actually means that the hormones that we will be discussing here related to calcium have 3 targets. The targets are either the bone, the gastrointestinal tract, or the kidneys. In the bone, that's where we store calcium. Okay, so we can either, deposit more calcium onto the bone or tap into that storage, to that calcium storage when needed. What about the effect on the GI tract? Well, some of these hormones can and will increase the absorption of calcium from the intestines. And the effect on the kidneys is that it can increase or decrease the amount or the levels of calcium, the amount of calcium that is being excreted in urine. Okay, so these are your targets. Again, we have no other options. It's either bone, GI tract, or kidneys. Now, on the top here, you'll find all of the hormones that favor bone formation. So these are healthy for our bones and will increase our bone mass. And those are insulin, insulin-like growth factor 1 or IGF-1, growth hormone, vitamin D. So vitamin D is considered a hormone. Sex hormones like estrogen and testosterone, and calcitonin. Calcitonin doesn't really have a major role in humans, and that's why it's kind of towards the end of the list. Now, the hormones that favor bone resorption, and that means the kind of taking away of calcium off of the bone, leading to decreased bone mass, are PTH or parathyroid hormone, cortisol, and thyroid hormone, T3 in particular. Now, for hormonal control, we have 2 major hormones that regulate plasma calcium concentrations, and that is PTH or parathyroid hormone and vitamin D. The active form of vitamin D is called 1,25-dihydroxy vitamin D, which means you take in vitamin D and you have to add 2 hydroxyl groups, 1,25-dihydroxy vitamin D. A third hormone, which is calcitonin, like I said, it has a very limited function in humans, if any at all. Okay, but it is mentioned, so we need to be familiar with it. Before we go in and talk about these different hormones and what they do, let's introduce the different bone cells and some of the terminology that we'll be using. So osteocytes, those are your mature bone cells, and those are responsible for maintenance of the cell. Remember, bone is a living tissue, so it is going to need oxygen, produce carbon dioxide, and so on. So these osteocytes are your mature bone cells and responsible for bone maintenance. They are made out of osteoblasts. So osteoblasts with a B are kind of like baby osteocytes. These osteoblasts are going to eventually mature into osteocytes. Osteoblasts helps in making bone by depositing calcium onto bone. And the only place that we can get calcium besides the bone will be from the blood. So in what is known as bone deposition, okay, we are going to be depositing calcium onto the bone, and that calcium will come from blood. Okay, so again, we have only 2 sources of that calcium, either in the bloodstream or in the bone. If we take the calcium and deposit from the blood and deposited onto bone, that is known as bone deposition, and that is the function of osteoblasts. Osteoclasts, on the other hand, break down bone tissue. It performs what is known as bone resorption. So it will, again, break down the bone tissue, releasing the calcium from bone, taking it from bone, and releasing it into the bloodstream. Okay, so that would be the function of osteoclasts. So again, osteocytes are your mature bones. Osteoblasts make bone in a process known as bone deposition, while osteoclasts tend to break bone or resorb the calcium from the bone in a process known as bone resorption and releasing that calcium into the bloodstream. Okay, now that we know what those terms mean, let's move on to the first hormone, and that's vitamin D. Remember, vitamin D has to be activated into that 125 dihydroxy vitamin D. And how do we do that? Is that we intake vitamin D in two different ways. So it's either vitamin D2, which is known as ergocalciferol. That's derived from plants. So we actually eat that. Cholecalciferol, on the other hand, which is vitamin D3, that is formed in the skin. So we do not intake that. But what happens is that the 7-dehydrocholesterol, which is a kind of cholesterol molecule that has been changed a little bit, when it's underneath the skin and we are exposed to the sunlight, the ultraviolet rays that are absorbed will change 7-dehydrocholesterol into cholecalciferol, also known as vitamin D3, as I mentioned. So both of these are inactive forms of vitamin D. Okay, you can find either kinds of these vitamins in vitamin pills or in enriched foods, but again, they are inactive and pretty much useless unless they are activated. Now that plasma vitamin D is going to be activated in two steps. The first step is in the liver, and the second step is in the kidney. It's the second step that is under the effect of parathyroid hormone. So we need parathyroid hormone in order to stimulate the activity or the activation of vitamin D in the kidney. Okay, that is the final step of activation. And when we do that, now we have high levels of active vitamin D, and that's going to increase the absorption of calcium from our GI tract. So again, the activation of vitamin D is dependent on the presence of PTH. Now, what is PTH? That stands for parathyroid hormone, and it's produced by the parathyroid glands. This is the posterior view of the thyroid gland. So remember that a butterfly-shaped gland in the front of the neck. If you flip it around and now you're looking at it from a posterior view, you can see 4 parathyroid glands. They're like little peas that are embedded within the back of the thyroid tissue. But they are totally separate in function from the thyroid tissue. So let's see what is the action of PTH. Okay, so increased levels of PTH will lead to, in the bone, that will lead to increased bone resorption. And remember, increased bone resorption means that we are going to stimulate the osteoclasts while we inhibit the osteoblasts. The increase in bone resorption will release calcium into our plasma. Another effects, or the other targets of PTH, are the kidneys. So we are going to increase calcium reabsorption from the kidney so that we prevent its loss in the urine. Okay, we'll keep it in our bodies and decrease the urinary excretion of calcium. And we will also again activate, remember that second step in the activation of vitamin D. And now that we have active vitamin D, that will increase the calcium absorption from the intestine. Okay, due to all 3 of these actions, that will increase our plasma levels in our bloodstream. So PTH secretion from the parathyroid gland is stimulated by low plasma calcium levels. And you could see how this kind of plays out. Now, calcitonin is a peptide hormone that is made by the parafollicular cells of the thyroid gland. So again, go back to the thyroid gland. We mentioned we had follicular cells that makes T3, T4, and we had parafollicular cells that secrete calcitonin. Okay, calcitonin is going to decrease plasma calcium concentration mainly by inhibiting osteoclasts. So I like to believe that calcitonin was named because it tones down the levels of calcium in blood. So calcitonin decreases our plasma calcium concentration, and it does so by inhibiting osteoclasts. When it inhibits osteoclasts, that leads to the inhibition of bone resorption. So calcium will remain in the bone. It is secreted by an increased plasma calcium. The stimulus to release calcitonin is hypercalcemia, or increased calcium levels in the bloodstream. And it's really, like I mentioned before, that it's not a main player in humans, except when the concentration is extremely high. Okay, again, it'll prevent that bone resorption. In some texts, it says that it will activate the osteoblasts in order to take that calcium from the bloodstream and deposit it onto the bone. And that, again, eventually will lead to the decrease in plasma calcium levels. Now we've got metabolic bone diseases. So these metabolic bone diseases are mainly due to the abnormalities of calcium or mineral levels in the bone. So we've got rickets and osteomalacia. They are both defects in the mineralization of bony matrix. So the bone is made out of, obviously, collagen proteins and other proteins, mixed in it lots of minerals, mainly calcium, but there are other minerals like phosphate, magnesium, and so on. But again, mainly calcium. So if there is any deficiency in the mineralization of bone in a kid, we call that rickets. If it's in adults, we call that osteomalacia. And that leads to the bone to be very soft and can be very easily fractured. And the major cause of rickets and osteomalacia is mainly due to a deficiency of vitamin D. So again, deficiency of vitamin D, now we cannot really absorb calcium from the diet. So even if they're if they're drinking enough milk, taking enough cheese, and so on, it doesn't really matter because they don't have vitamin D in order to absorb calcium. So calcium cannot be absorbed except in the presence of vitamin D. Now, osteoporosis is an imbalance between bone resorption and bone formation. Throughout life, remember, bone is a living tissue. Throughout life, our bones are always, there's a balance between resorption and deposition. Up until maybe, some textbooks even say in the early 20s, but let's be a little bit positive here and think more like into the 40s, 50s, after menopause, where bone resorption is much higher than bone formation, and that is going to lead to the increased fragility of bones, and that increases the incidence of fractures as well. Osteoporosis tends to happen in cases of immobilization. Okay, so decreased physical activity is a risk factor for osteoporosis, and it also in patients that have excessive plasma concentrations of hormones that favor bone resorption. For example, high levels of PTH, as it may be due to a tumor. Or in patients that have deficient plasma concentration of hormones that favor bone formation. So remember this list at the very beginning that we talked about. The hormones that favor bone formation and the hormones that favor bone resorption. Okay, any change in those, if you have excessive plasma concentration of a hormone that favors bone resorption, that can lead to osteoporosis. While a deficiency in the plasma concentration of a hormone that favors bone formation can lead also to osteoporosis. Osteoporosis is most commonly seen with age. Okay, it is kind of considered, quote unquote, normal aging process. And the best treatment for osteoporosis is actually prevention. So you want to prevent it from occurring as opposed to it happening, and then you try to treat it. Okay, because it's something that is a little bit resistant to treatment, and you could actually find out that person has osteoporosis after the fact that they got a fracture. So you want to avoid that from happening. So your focus for osteoporosis is prevention rather than treatment. Okay, like I said, everybody loses bone as we age, but it's more common in women, especially after menopause. Estrogen is protective against that. So go back to the list of the hormones that help in making bone or favor bone resorption, bone deposition. You'll find estrogen is one of them. So when we, after menopause, when we lose estrogen, we've lost that protective effect. And that's why osteoporosis tends to happen after menopause in women. Okay, so again, prevention is your best option here. Now the treatment options, if you were not able to prevent it from happening and you already have a patient that has osteoporosis, what do you do? Well, since estrogen is protective, then we can give them a little bit of estrogen in the form of HRT, so hormone replacement therapy, but never give estrogen alone, because unopposed estrogen, meaning the estrogen without anything to oppose its effect, is a risk factor for endometrial cancer, which is uterine cancer, and breast cancer. So if anybody gets estrogen, it would have to be in together with a little bit of progesterone to kind of oppose that estrogen effect. A regular weight-bearing exercise program, and that helps in prevention as well, actually. Weight-bearing does not mean that you want them to carry weights. Weight-bearing exercise means that you want them to use their body weight while they're exercising. So, for example, swimming is not a weight-bearing exercise program. Swimming eliminates the weight of the body during motion. So it's really good for joints, so to keep the range of motion of joints, but it doesn't give us that effect on bones that we want to prevent osteoporosis. So what you want is the pull of the muscles and the tendons on the bone, and as it pulls on the bones, that is going to increase the blood supply and keep those bones healthy. So again, a regular weight-bearing exercise program like walking, jogging, if they are able to do so, and so on. So anything that has them use their body weights. Adequate dietary calcium and vitamin D intake. So remember, calcium intake without vitamin D is pretty much useless. We've got some drugs, for example, bisphosphonates, that interferes with the resorption of bone by osteoclasts. We also have SERMs, and these are known as selective estrogen receptor modulators. So instead of giving them estrogen and dealing with that side effects, we can give them something that is an estrogen receptor agonist. Okay, it'll attach to the estrogen receptors and leading to the same effect of estrogens in order to compensate for the low estrogen after menopause. Now, dealing with hyper and hypocalcemia. And this is when we were saying that, extremes of range and calcium levels can lead to neurological and muscular problems. So we'll see how that happens. First off, hypercalcemia, which means abnormally high levels of calcium in our blood. The causes are primary hyperparathyroidism. And primary, again, means that the primary cause of the pathology is in the actual parathyroid glands themselves. Okay, it could be caused by a benign tumor in one or of the 4 parathyroid glands, or the parathyroid glands are totally normal, okay, and that would be, the cause is something else. Okay, so for example, some cancers produce a protein that is called PTH-related peptide. So it's very similar to PTH, and it would attach to the PTH receptors, leading to hypercalcemia. And that is known as the humoral hypercalcemia of malignancy. So these patients would have a malignant tumor, and that malignant tumor is making this PTH-like protein. Or another cause of hypercalcemia would be the patient is taking too much vitamin D. So excessive ingestion of vitamin D. Now, what are the symptoms of hypercalcemia? There is tiredness, lethargic with muscle weakness. Lethargy means, fatigue and muscle weakness. And then because of the effect of high calcium levels on the GI tract, there would be nausea and vomiting too. Now, hypocalcemia, that's the other extreme. Again, a cause could be primary hypoparathyroidism, so due to loss of the parathyroid gland functions. And this is something, so if you guys are going to be working in the future or now in post-surgical, taking care of patients after surgery, so something that you want to keep your eyes on if somebody is getting a thyroidectomy. So we talked about the parathyroids being in the back of the thyroid gland. Sometimes they are deeply embedded within the thyroid tissue, that if a patient gets a thyroidectomy, which is a surgical removal of the thyroid gland, that sometimes we can't, I don't want to say it's a mistake, but sometimes the parathyroid glands are actually removed with the thyroid tissue. So somebody has thyroid cancer, all of that will be removed. So now this patient, you've removed their parathyroid glands. They no longer have PTH. Any thyroidectomy patient, post-surgical, you would have to look for reflexes. Okay, so they can sometimes start seizing or having seizures, muscle spasms, and so on. That is because of the dangerously low levels of calcium that happens due to the accidental surgical removal of the parathyroid glands. Okay, so that is known as primary hypothyroidism. Pseudo-hypothyroidism, which means that nothing wrong with the parathyroid gland. Actually, the parathyroid glands are making not only normal levels, but sometimes even higher than normal levels of PTH. So what is the problem? The problem is that the target cells, their receptors are resistant to PTH. So in pseudo-hypoparathyroidism, there is resistance to PTH at the target level. So even though PTH levels are normal or actually even elevated in most of the cases, and that's why it's known as pseudo-hypoparathyroidism, because although the patient is showing signs and symptoms of low PTH levels, but if you take a blood sample, their PTH levels are actually above normal. But again, the target cells are resistant to PTH. Now, a third cause of hypocalcemia is secondary hyperparathyroidism. And this is due to secondary to another disease. For example, kidney failure. In patients that have chronic renal failure, we have lost that second step of activation of vitamin D. So now we cannot activate vitamin D. We cannot absorb calcium from the intestines. So we have hypocalcemia. That is going to stimulate the parathyroids to make to make PTH hormone. Okay, so although the patient has hypocalcemia, the parathyroids are trying to compensate for that by increasing their production of PTH. So they have secondary hyperparathyroidism, but their calcium levels are low. So make sure you are good with this. Primary hyperparathyroidism leads to hypercalcemia, while secondary hyperparathyroidism due to renal failure leads to hypocalcemia. Now, for the symptoms of hypocalcemia, we have increased excitability of nerves and muscles. So remember I said that patient that just came out of surgery, of a thyroidectomy surgery, you want to check the reflexes, you want to look for the increased excitability, seizures, muscle spasms, that's known as a hypocalcemic tetany, and increased neuronal excitability. The treatment would be to give calcium salts and vitamin D. Okay, if it is due to the removal of the parathyroid glands, like in the primary hypothyroidism, the patient would have to be getting synthetic PTH for life. So that's all, folks, for this chapter, and I will see you in our meeting.